Thank you very much. We'll have Dr. Yazan Eldewari for management of thoracic aortic intramural hematoma.
Thank you very much.
Did I pronounce it right? I mean the name.
Better than most. Thank you.
Okay.
I've been called all sorts of things, so this is good. Thank you very much. I'm very honored to be here and in this beautiful country, Dr. Musad. Thank you for the kind invitation, and I look forward to listening to many more educational lectures in this meeting. The topic is management of type B thoracic aortic hematomas, intramural hematomas. These are my disclosures. None of them are relevant to this talk. IMH, intramural hematomas, is part of the acute aortic syndrome presentations, and it is one part of the aortic dissection spectrum, which is made of plain known aortic dissection, penetrating aortic ulcers, or intramural aortic hematomas. We will concentrate on talking about PAUs, penetrating aortic ulcers, as well as intramural hematomas. Now, intramural hematomas is a largely radiographic finding. The diagnosis is made by CT scan after a patient presents with acute chest pain, after ruling out cardiac conditions and looking for acute aortic conditions. A CT scan would identify a circular or a crescentic thickening of the aortic wall without opacification with contrast, and therefore detecting no detectable blood flow within the aortic wall, but only detecting a hematoma within the aortic wall. Now, the pathophysiology is really not purely defined. The first theory was that this was due to vasoviscorum rupture, or rhexis. This was never validated, and in fact it is very questionable because the pressure within the vasoviscorum, and therefore the intramural hematoma that may result from such a thing, would not be large enough to overcome the pressure within the aortic lumen itself. So it is hard to explain IMHs by this theory. The other theory is that this is actually an acute dissection that resulted in thrombosis of the false lumen due to the absence of outflow tract or an outflow fenestration into the true lumen again, and therefore an intramural hematoma is therefore more likely to be considered part of the spectrum of aortic dissection. Now, penetrating aortic ulcer, on the other hand, is due to erosion or a defect in the elastic lamina of the endothelium, and therefore resulting in separation within the medial layers as blood flows between the adventitia and the intima, and this is identified by high-resolution CT scans as flow of contrast as an ulcer-like projection from the aortic lumen into the media. Now, the natural history of a intramural hematoma or penetrating aortic ulcer can either be very favorable, which would be a complete resolution or resorption with time, or unfavorable progression to either an aortic aneurysm, a pseudoaneurysm, or a plain dissection, or even complete rupture. And therefore, it is important to decide or identify on the initial CT scan which patients would have a favorable prognosis versus an unfavorable progression. And therefore, we've started for the last 20 years trying to define the ways that would let us identify the unfavorable prognosis. Now, this is a study by Dr. Michael Dake and colleagues looking at patients who did have a penetrating aortic ulcer associated with intramural hematoma compared to patients who did not have a PAU with the intramural hematoma. And the interesting finding here was that patients who did have a penetrating aortic ulcer had a more likely occurrence of a progressive course resulting in aortic rupture, mortality, or IMH expansion compared to patients who did not have a PAU identified. Similar other studies also looked at the presence of focal intimal disruption, again a variant of PAU, or the absence of that, and looking at the impact of that finding with IMH on mortality. And patients who did have focal intimal disruption also had a higher incidence of mortality. So this tells us that those patients who have a focal intimal disruption should be looked at and considered for more aggressive treatment with TVAR as opposed to the other treatment option in the patients who do not have penetrating aortic ulcers, which should be medical management and blood pressure control with anti-impulse therapy and beta blockers. So in general, TVAR is indicated for patients who have intramural thoracic hematomas in the presence of PAUs or any intimal disruption. I'll show a couple of cases showing good favorable anatomy and unfavorable prognosis. This is a patient who had intramural hematoma after was noted on CT scan after presenting with chest pain. Again, if you look at the CT scan, you see no evidence of intimal disruption or an ulcer-like projection within this thickened aortic wall. This patient did well with medical therapy, and this is a CT scan just 1 month after that presentation with blood pressure control, showing almost complete resolution of that thickening in the aortic wall. Another patient presented with severe back pain, had some cardiovascular history. This patient had that focal intimal disruption and a large intramural hematoma, and you can see those ulcers in the aortic wall at multiple levels. Here also at the level of the renal artery. Based on the data that I just showed, this patient was treated with TVAR, sealing those intimal tears, and also sealing it distally with a covered renal stent with good resolution of this flow, and with follow-up, this patient had better remodeling in the aortic lumen. This patient had a proximal aortic dissection and the distal aortic hematoma, and because of that intimal disruption, this proximally was also treated with TVAR. Now the question is, of course, which patients do better, those with medical therapy or TVAR, looking at all patients who present with intramural hematoma to start with. This was looked at in multiple studies. This is a meta-analysis looking at 9 studies, had 160 patients in each arm. Although patients who underwent TVAR were more likely to have unfavorable anatomy with a penetrating aortic ulcer or intimal disruption, those patients, although they had worse presentation initially with TVAR, had comparable rates of death or IMH regression. But patients with TVAR, looking at the secondary endpoints, had less likely rupture or IMH progression, and less likely to have further dissection in the future. Now, medical therapy, we looked at the outcomes of medical therapy in patients who did not undergo TVAR at our institution. We had around 70 patients who presented with IMH. Half of them had PAUs or thick aortic hematomas and were treated with TVAR, and the other half did not have that because of the lack of high-risk features. Interestingly, when we looked at those patients who did not have intervention initially, almost half of them ended up needing intervention with time because they did progress eventually to have either a dissection or aortic enlargement. So in general, intramural hematoma is not a benign finding. Most patients will end up requiring surgery or TVAR in the future, and medical therapy has a high incidence of failure. And this was found on multiple other studies later after our study. So in general, TVAR in IMH is accomplished with low perioperative morbidity and mortality and should be considered liberally initially. TVAR is indicated with in all patients with complicated IMH, whether they have ruptured or unresolved pain. Those who have uncomplicated IMH should be considered for TVAR if they have intimal disruption, and can also be considered if they have a significant thickness of the hematoma. And in general, patients who you end up discharging with medical therapy should be followed up with close radiographic surveillance, because most of them will eventually need surgery. Thank you very much for the kind invitation.